Hi, this is Elliot Fishman. Welcome to part 3, and that's 3 of 3 of CT of the large adrenal mass. Follow, biopsy, or resect. Now, where were we? Well, at the end of part 2, I mentioned lymphoma as one of the adrenal masses. Now, lymphoma is interesting. We just wrote an article about that. Hopefully, it'll be accepted soon. But it could be primary or secondary involvement of the adrenal gland. Most of the time when you have adrenal involvement, it's secondary. It's multi-organ system lymphoma, liver, spleen, kidneys, nodes, bowel, adrenal are all possibilities. But occasionally it can be primary to the adrenal. The only site of disease is the adrenal. It can be unilateral or classically bilateral. Adrenal gland involvement in lymphoma is not rare, but primary adrenal lymphoma is indeed very rare. In looking back at how many cases we had at Hopkins over maybe a 20-year period, it was less than about 15 cases. So you can see it is indeed a very rare entity. However, I believe you can, in some cases, suggest that possibility. And we have, because if you think something is primary lymphoma, then you'd be willing to biopsy it. If you're thinking about ACC, then you can't biopsy it. So it's a very important diagnosis. Primary adrenal lymphomas, less than 1% of all non-Hodgkin's lymphomas. Most patients present with nonspecific symptoms, fever, abdominal pain, and weight loss. Especially in patients with bilateral involvement, which is classic, adrenal insufficiency may be the presentation. On CT and MR, primary adrenal lymphoma appears as solid masses, variable size. I think the way I can make the diagnosis, if it maintains the adrenal shape, even though it's very large, it's often homogeneous but can be heterogeneous in appearance. If it's only unilateral, then it could look just like metastasis, and even bilateral, unless you have that triangular configuration, can look simply like metastasis. Calcifications are uncommon, and again, unilateral can occur, but bilateral is what's classic. It usually occurs in older men, median age of about 65, bilateral involvement, 73% in one study, and about half of patients actually develop symptoms of adrenal insufficiency, as I mentioned, and of course, those are the patients with bilateral disease. In terms of size, large tumors exceeding 10 centimeters with infiltration. Masses enlarge and expand the adrenal glands, and again, maintaining that shape. That's what makes them somewhat unique, but again, solid, heterogeneous, some enhancement, not supervascular, and you typically don't see the neovascularity I showed you with primary adrenal cortical carcinoma. Here's a patient with weight loss, large left adrenal mass, could be an ACC, could be metastatic disease. Those are all possibilities. I don't see anything else. And this, upon removal, was a primary adrenal lymphoma. Again, the thought was that it was going to be a primary ACC. Here's one that's a bit easier because it begins in the adrenal, but it's infiltrating. In cases the renal arteries involves the upper portion of the patient's kidney. You could have even considered, could this be kidney involving the adrenal bed? But this was primary adrenal lymphoma with extension and infiltration. That's a little bit easier diagnosis for us. Here's another patient with large bilateral adrenal masses. Again, metastasis is a good consideration. Melanoma, hepatoma. They're not very vascular, a little bit necrotic. They do maintain, if you really take a 50,000-foot view, the patient's adrenal gland shape. Here it is on the patient's coronal views, areas of necrosis. But let me go back just again to show you that triangular shape that I'm talking about. But again, if you told me this is metastatic disease, I would have a hard time arguing against you. Here's the cinematic. You can see areas of necrosis, particularly in the left kidney, but also the right kidney. Here's another patient. You see, in this case, the adrenals really do look oval. I look at this, even on the non-contrast, I'm thinking primary adrenal lymphoma. Not very vascular on the arterial phase. As you go from arterial to venous, There's necrosis present, particularly in the right adrenal gland. It's interesting that two adrenals do not enhance. Similarly, there's more necrosis in the right than there is on the left. And the adrenal shape, that triangle, is particularly well suggested on the coronal views. Very nicely shown here as well. And here it is a cinematic, a little bit more necrosis on the right, well-defined masses, no adenopathy, no other organ involvement. There's the coronal view, the volume rendered in the with cinematic rendering to be specific, which shows necrosis better than any other technique. Now, adrenal lymphoma in this article by Al-Shahrani tends to grow in an infiltrative pattern, maintaining that adrenal shape. Okay, on CT, an adrenal lymphomatous mass can be homogeneous without washout features, similar to other malignancies. And again, calcification is rare, so that's not going to be a problem typically. Now, if you ask the question, what about bilateral masses? What else could be bilateral? Pheos, 40% of the time, can be bilateral. TB, lymphoma, 10%. Mets, about 6%. Adenomas, about 4%. Macronodular hyperplasia, and others. So, again, lymphoma is one of the things that gives you bilateral masses. Okay, what else? Pheochromocytomas. We think about pheos in patients with hypertension. We think about pheos, again, 70% are incidental findings, so it's not always someone presenting with a clinical presentation. The thing about pheos, they're very vascular. They wash out like adenomas because they're so vascular, but the key finding is they typically enhance above 110, usually above 120 Hounsfield units. Some people use 110, some use 120 as a cutoff. But surely when you start seeing lesions at 140 or 160, it doesn't matter what the washout value is. That's, to me, a pheochromocytoma. Pheos are the rule of 10, right? Multicentric, extra-adrenal about 10% of the time, including the majority in their organ of circumcondyle, and about 10% are malignant. In terms of large masses, pheos are in that category. They can be very vascular, as in this case. You could consider metastatic renal cell or other Mets as a possibility. Here's another solid hypervascular right adrenal mass. Primary ACC, I guess I can't exclude it. They're not so vascular, so diffusely. You got to think about pheo, get the lab values, and you'll be able to reach a diagnosis. But pheo should be suggested. And although this talk is not going to focus on pheos, pheos can also be cystic and necrotic. This patient presented with a lung nodule, which is vascular. You saw the right adrenal mass, which is vascular and necrotic. You could think about an ACC. Pheos a very good choice. Now remember, pheos are not uncommonly cystic, so solid and cystic. You could consider metastasis. I showed you a ganglion aroma, but it's too vascular for that. Thinking about a primary ACC is a very good choice. Size, vascularity, necrosis, lung met. Well, this ended up being a cystic pheochromocytoma. Here it is a little bit on the venous phase imaging. Cystic pheos, as I mentioned, are not uncommon, but it's rare for me to see one that has so much vascularity around the edge and so much necrosis centrally. As pheos enlarge, they can undergo ischemia and necrosis, which is why you have cystic changes and that heterogeneous enhancement. Cystic pheos are rare, but they do occur. We talk about a rim sign. And again, this was a very nice definition. Cystic pheo differential is other cystic lesions, including pseudocysts, lymphangiomas, necrotic metastasis. There are a range of possibilities. Now, the last thing I'll mention is we always forget, because it's so uncommon, that you can have unusual primary sarcomas of the patient's adrenal glands. Now, these are very rare, and I don't think I've made a call of one of these probably ever, because they all look to me like, or almost look to me like, primary adrenal cortical carcinomas. But they are pleomorphic sarcomas, leiomyosarcomas, carcinosarcomas, and epithelial sarcomas. So some very big words. Primary adrenal pleomorphic spindle cell sarcoma, exceedingly rare, okay, in this article by Rajendra. And here's just a big right adrenal mass. In fact, on the non-contrast, you can't say it wasn't a renal mass. But there it is. Look at that vascularity. Looks a little bit like that pheo. Looks a little bit like that lymphoma, though too much vascularity for that. Looks like an ACC. Look at the vascularity present, particularly around the edge of the lesion. And when I look at the images with MIP, look at that neovascularity. My call on this case, I wouldn't think twice, is ACC. I don't think it's a pheo. I don't think it's lymphoma. I don't think it's metastasis. I think this is a primary ACC, but it wasn't. It was a sarcoma. Here it is on the washout value with the areas of necrosis. So sarcomas are rare, and only on biopsy, which you're not doing, only on removal do you make the diagnosis. And here it is on the patient's cinematic rendering as well, very nicely showing in the neovascularity as well as the sarcomatoid features of the lesion. But again, with all that neovascularity, ACC is the first thing that comes to my mind. Another patient, weight loss, left adrenal mass, extensive adenopathy. Lymphoma is a good thought. Metastasis are a good thought. Maybe it's something from the kidney, but whatever it is, it's infiltrating the adrenal, it's infiltrating the paraortic region, encasing the renal artery, encasing the aorta, encasing the SMA. Here it is here, a really, really large mass. On these images, I can't say that it's not the kidney, like an infiltrating renal cell carcinoma, but when you have all the images, it's really in the adrenal gland, with secondary involvement down to the kidney, a really unusual case, and that was an epithelioid angiosarcoma of the left adrenal, which grew downward, invaded the kidney, and there's some areas of hemorrhage in the kidney. Again, whatever this was looked very aggressive, and it is very aggressive, but I don't think that was the thing that was on the tip of my tongue, and it's unlikely for any of us we're going to make that call. Now, what about this case? Again, an adrenal mass. There's some enhancement present. We could think of a number of things ranging from ACC to unusual metastasis to some unusual atypical appearance of a benign adenoma. But it's large. It's going to come out. There's some of the vascularity in the lesion, very well defined, no local invasion, but there is prominent vascularity. That alone pushes you into the malignant category. And this was resected and was an epithelioid angiosarcoma. So angiosarcomas are rare tumors anywhere, most common liver and spleen and soft tissue, but can occur primarily in the adrenal gland as well, but very, very uncommonly. So concluding, adrenal masses over 4 cm have a big differential diagnosis from benign to malignant. We can't always be right, but I think there are certain signs that help us in making the best diagnosis. There's certain signs that allow us to figure out how to manage the patient and when we need to go to surgery, and the rare cases when we could do a biopsy, like when we suspect lymphoma. So it's important to understand these lesions, understand the spectrum, and understand how difficult it is to often get the right diagnosis. So with that, I thank you for your attention, and again, reminding you about the article from Mayo Clinic, clinical context, hormonal assessment, image phenotype, together can help you determine how to manage these larger lesions. And again, multidisciplinary approach is indeed going to be everything. So with that, have a great day. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.